Hello everyone, David Wilson here again from Dr. Stem Cells, and in today's video we're going to talk a little bit more about what stem cells are and how they can work. So stem cells are the stem cell progenitors or the cell progenitors of other cell types. So if you have a stem cell, it'll be able to become something else, and in so doing is actually able to provide the body with the potential for new growth, and in the case of adults then also for healing and repair. We often talk about stem cells and we mean mesenchymal stem cells, sometimes referred to as medical signaling cells or medicinal signaling cells. And these cells are found in bone marrow and fatty tissue predominantly. They're also found in some other smaller volumes and smaller concentrations in other places. The reason it's important to discuss these cell types is because within the human body, a mesenchymal stem cell has already the potential to become a osteoblast, so it can grow bone, chondrocyte can grow cartilage, adipocyte can grow fatty tissue, and myocyte can grow muscle tissue. What we know about these cell types then is that this entire lineage, the mesenchymal lineage, is perfect, or ideal, maybe is a better way to say it, for growth and repair of musculoskeletal injury and cell stress or wear and tear, or even cell death. This means that we now have an exciting new avenue to explore. And in today's video then we're going to actually look at a paper which looked at this exact issue and compared stem cells directly against hyaluronic acid. The stem cells in this paper are also referred to as stromal vascular fraction, and the reason they're called that is because these stem cells have in fact a component when you take them, especially from fatty tissue. Not only do you get mesenchymal stem cells, you also take some of the progenitor cells for venous and vascular tissue. So that means that when you provide a mix, which is more of a fatty mix rather than just stem cell alone, you actually include some other tissues that may also have some serious healing potential. But let's get down and take a quick look at the paper. So when we look at this paper was published here, you can see International Orthopedics. It's a paper from 2018, so it's a few years old now, and you can see the purpose of this study was to compare the clinical and radiological efficacy of adipose-derived stem cells or stromal vascular fraction versus hyaluronic acid in patients with bilateral knee osteoarthritis. Now, this paper is a double-blind, randomized, self-controlled trial. That means that the patients didn't know which knee received stem cells and which one received hyaluronic acid, and they were used to control themselves. And this is a really good study type because neither the doctor who did the injection or the practitioner who did the injection nor the patient know which syringe contains which, so it really minimizes risk of bias. The good thing about doing a self-controlled trial like this is that you have two knees with arthritis and you don't know which knee is worse or better. You give a random injection to each knee. And the other thing which really is useful to try and eliminate bias here is that, well, the patient will have the same lifestyle before and after the injections for both knees. It's not like they can go, and unless they decide to start hopping, they're not going to change dramatically what they do with each knee. This means that you can actually say that you've really minimized differences in how each group is treated. So they have 16 patients. It's not a massive study, but they had bilateral knee arthritis grades 2 to 3, which means not the worst kind of arthritis. Grade 4 is even worse. And they have pain evaluated at 4 or greater on a 10-point scale. They were enrolled in the study, randomized into 2 groups. Each group received 4 mL of stem cell mixture in one side of knee joints and a single dose of hyaluronic acid in the other side. The clinical evaluations are performed preoperatively and postoperatively, 1 month, 3 months, 6 months, and 12 months. Now, the other thing we'll talk about in a few moments is what would happen if they'd followed even further on, but let's just go right down to the results. First of all, no significant baseline differences were found between 2 groups. This is not a surprise because as the groups are in fact the same patient with 2 separate knees, they ought to be very similar. Safety was confirmed, no severe adverse effects. That makes sense, and that's in keeping with what we know. If the stem cells are from your body, for your body, how could you possibly have a strange reaction? Your body will accept them, or at the very worst, reject them and kill them, but it won't have a graft versus host or a rejection reaction. They are your cells and your body is in full control of them the whole time. The next thing which is interesting is the 12-month follow-up. The SVF, or the stem cell treated knees, showed significantly improvement in the mean VAS, that's a visual analog scale for pain, also in WOMAC scores and ROM, range of motion, at 12-month follow-up, compared with the baseline. In contrast, the mean pain score, WOMAC, which is a pain, function and stiffness score, and range of motion of the control group became even worse, but not significant from baseline to the last follow-up visit. Worms and Mocart measurement revealed significant improvement of articular cartilage repair in SVF-treated knees compared with hyaluronic acid-treated knees. This suggests that stem cell treatment, to summarise here, is safe and can effectively relieve pain, improve function, and actually repair cartilage defects in patients with knee osteoarthritis. Now, we could go down through this and look in more detail at all what they've seen. Yeah, here we are. We can see the layout here. Patients randomised. They receive hyaluronic acid or fluid in either knee, 16 knees, 12-month follow-up, and they then have the scores. You can then see clinical outcome. We can go down here and see the difference in the age groups and the patients, female to male. You can also see which leg was preferred, and we can even go down and see radiological evaluation. So this is a really good study in terms of what they have followed up. They have followed up with MRI and with studies of the cartilage quality, group test, group control, and VAS. The higher is worse, so lower is better. So you can see that number A here, the red line goes lower for the test group. In B, we have the range of motion. The more degrees, the better. So again, higher is better in this one. In C, WOMAC pain, lower is better, and WOMAC stiffness, lower is better. And you can see a significant change, and the lines don't cross over. The only time when the lines may cross over is at 1 month post-operative. You can see that there is a chance here for less statistically significant. The lines there which show the range, it should not cross if it's statistically significant. Here we have worms. Worms is a radiology finding, and that's trying to see if there's any difference. P-value less than 0.01 means very significant. Whole organ magnetic resonance imaging score, so that's what the worms stand for, and that's looking at the knee. And then we go down here to the cartilage. Now, at 12-month follow-up, what's most interesting, I think, for my patients and for you watching this video should be, if you look at table 6 here, changes during the 12-month follow-up. Cartilage, minus 7.8 in the test, 2.56 in the control. And values are expressed as a mean plus or minus standard deviation. And the reason for this then is that we want to see, so at 6 months, it's at 7, at 12 months, it's 12. Whereas over in the control group, 2.56, 4.13. So you can see that there is a significant change here. Total score, 11.38 versus 12.81. And you can see then again, very statistically significant score here. Finally, let's go down to MOCART. The score given here, you have all of the different things here. Degree of deficit filling, complete, 20. Hypertrophic 15, and so on. This is very interesting. So if we now want to look quickly at the discussion, in this paper we report our findings comparing the stromal vascular fraction, or the stem cell versus hyaluronic acid, 16 pairs of knees, and they go on to just summarize a little bit of what they have done. In the test group, the joint showed statistically significantly improved in scores, pain score, range of motion, pain and stiffness scores from WOMAC compared to baseline at 12-month follow-up. But the mean visual analog scale of 12-month visit increased significantly compared with that of 6 months. The takeaway from this study then is that stem cells can actually induce cartilage repair, they can reduce pain, they can increase range of motion, they can reduce stiffness, and they can fill in cartilage defects. Now I want you to think, if this is a joint and you have the surface over the top here, which is the skin of my hand, as you start to get holes in that surface, that's where you start to get your pain from. And the patient who has a cartilage repair will actually have that covered over again so that that grows back to a weaker form of cartilage, but cartilage nonetheless, and will have significantly reduced pain in that joint, because almost like a hole in your tooth, if you have a hole going into the pulp, you're going to feel it, the nerves there, they're exposed, painful. The same with the knee joint or any other joint. As your joint wears down, you come into where the joint has nerve and bone marrow and pulp, and that is where you're going to feel a lot more pain and tenderness. But as this grows over, as this heals and repairs itself, people should be able to have longer life and healthy function of these joints. And hopefully then, as we'll see in another paper, which we can discuss in another video, we should be able to see where they can push the requirement for a new operation or a new knee or a replacement knee way down the line, maybe even as long as 10 to 15 years. But we'll look at that paper in another video. The other thing we want to just highlight from this discussion here is that the MRI follow-up showed significant improvement of the worms in knees treated with stem cells, reduction in cartilage and marrow abnormality subscores, they decreased by 12. They also show, MOCART proved that, here we go, let's go down, the test group has statistically significant superior articular cartilage repair, both at 6 months and at 12 months. So this is very, very exciting stuff. Let's take a quick look then at the limitations of the study. Finally, we can just briefly look at conclusion. Results indicate that autologous adipose-derived stem cell is safe and can effectively relieve pain, improve function, and repair cartilage defects in patients with a grade 2 to 3 arthritis. It's therefore believed that adipose tissue may be a good cell source for cartilage regenerative engineering. Limitations. Several limitations. First, the follow-up period is short at 12 months, and I 100% agree with this. This is a very fair criticism, and it's good of the authors to highlight this in this paper, because 12 months for a regenerative therapy, something that's growing, well, you can look at a child or a baby or a teenager, you're never finished growing after just such a short period of time. And they say here, we need more follow-up time to determine the long-term effects of SVF. Secondly, the sample size is small. That is correct. Now, they could have probably made a larger sample size, but that's also partly limited by funding and by resources, because these take time and they're relatively costly. Third, second-look arthroscopy and pathological biopsy of newborn cartilage tissue is the gold standard for evaluating cartilage repair. However, arthroscopy and biopsy are invasive and inconvenient for dynamic follow-up, and therefore difficult to carry out in China, they say here. I would say in general, because again, if we want to say we first do no harm, and you've put in this study and you're getting improvement, and then someone goes in with a biopsy and they punch a hole through the cartilage and take that bit away to look at in the microscope, you might get worse. And that's a harder thing to ethically support. Fourth, we could not find a clinical rating index aimed at unilateral knee joint. That patients should complete 2 same questionnaire focusing on the individual characteristics. Fifth, it is unknown whether these injections in one knee could influence the opposite knee. Sixth, we did not find actual association between stem cell density via cell viability and outcomes. More studies are needed to explore the cell dose effect of stem cell treatment. And this is all very good. So if we look at this, what would we like to see in the next study? Well, we'd like to see a study where you have an absolute cell count so that you know how many cells to give and what dose to give. There are different ways to prepare stem cells from fatty tissue, and SVF ends up being a fatty emulsion or a very fat-rich substance. There is some argument to be made that that may be superior to just pure stem cells, which are centrifuged out of the fatty mixture. The difference in these two are that the fatty tissue might actually be a useful resource for nutrition for the living stem cells. As you prepare an SVF, the cells get broken down, you mechanically stimulate, and you might even irritate and destroy some of those cells. And in so doing, the fat cells can actually end up being a resource for hungry or active stem cells to grow with, especially because inside a joint there is not much in way of resource or by way of resource. Joints are, by definition, nutritionally poor, and they're also oxygen poor. And that means then that for patients with a stem cell injection, one of the limiting factors, and especially limiting to growth rate, is going to be the actual intra-articular environment. Another reason that it's important to look at some of these limitations, and hopefully in the future we'll know better, is because if we could find an absolute stem cell count of 1 million, well, then you might be able to give someone a lower volume injection with the same number of stem cells. Or we could find perhaps a volume of stromal vascular fraction that's correct, 2 mils or 3 mils, because once you pass the 5 milliliter injection mark for a knee joint, you're going to start having pain and stiffness immediately afterwards. And that will increase your patient dissatisfaction, especially in the short term, and it will also increase the risk that the patient biomechanically burdens or loads the joint in the wrong way, and can actually give them other aches and pains and strains because they're not putting their weight down as they should be. So there are a lot of things to discuss, a lot of things to consider here. A really interesting paper, and I hope this has been useful for you. I hope you've learned a little more about stem cells, and we'll talk more in another video about stem cells as we look at stem cells versus operation. It's a really exciting paper. It's not very big either, unfortunately. It's quite a small study, but it's definitely worth talking about. So I'll see you in the next video. Have a lovely day.